to Beatrice, to Achim, or to Anna, then just feel free. There's one question. Please introduce yourself.
I'm Kun Block from European AIDS Treatment Group. It was very quickly, so maybe I'm wrong, but I had the impression there were very few patient organizations replying, or am I wrong? And my question would be why? Because is it because they didn't exist in some countries, or because they just didn't reply? Which would be really
it's both. It's both. We try to make ELPA branches as much participant in this as possible, because in those countries where they were involved, the discussion with the ministries of health has been a lot more interesting and intense. Because when we get feedbacks from different sides, then you know, the discussion goes in a different thing. But you also have to think that ELPA has no branches in all European countries, or in all countries that they are in the project. So it's both. Yeah.
But I would expect that there are other hepatitis local
right,
groups.
But they are, for example, in Ireland. They don't belong to ELPA, but they were not very much giving any information. And for me, it was truly speaking a big surprise coming from the HIV field, because the hepatitis patient organizations out of ELPA, they were very comfortable with the situation, even though some of them, for example, in Latvia, they are really suffering a lot, and they are pretty much at the bottom. They do not have a lot of things implemented. However, you talk to them, and they are more patient organizations that they are taking care of the patients. They are not activists. They do not care about policies, basically. So they try to help their people, and they were not interested at all. Or also, in many countries, they do, and that comes in. We have one indicator that there is a patient organization in the country, a national, a regional, and in many countries they do not have. It does not exist. You know, in Slovenia they don't have, in Switzerland they don't have. You know, there are countries still that I will expect, or in Spain they have one in Catalonia that is actually taking over the whole Spain. You know, so it's not so many branches, and with the time many branches are disappearing more and more.
So if I may, maybe that is then a conclusion also to, I mean, I see public awareness, but I think then patient group awareness is
and then
also
we have something else, that it's that there is two different cases here of hepatitis. Hepatitis B in general population, mainly hepatitis B, and hepatitis in drugs using mainly communities. And when they create some patient organization, the interest from both groups, they have been kind of very conflictive, with ending up in dissolving the patient organization. And some additional thing is that the patients, they get cured, something that is not happening in the HIV field because it's chronic. And only those chronic, or a lot of these people, when they get cured, they actually get out of the patient organization.
So Beatrice, you just mentioned this one, the different patient groups, and you indicated that most of the data were generated only for individuals who have actually medical cards. And the proportion, obviously, in some countries of hepatitis patients without a medical card may exceed 50%, 60%, I don't know. So is this somehow reflected in the index? Do we need to work on this to update this one and to introduce an item on this issue also?
Right. I think one indicator about, for example, migrant access to healthcare, it would be very useful. Because I collect this today for the talk, and I just wanted to mention. For example, in Bulgaria, genotyping before treatment for patients socially insured is covered, but if you are not with a card, then you have to pay privily. And in Ireland, screen founding is for free, but only if you have some medical card. So all those drug users that do not pay insurance, then they have to pay for their own screening. And we are preventing, I don't know if a drug user at one point will decide to spend the money in getting a screen for hepatitis or buying some new dose. You know, so that's an additional problem. I think it should be addressed with a new indicator. Yeah.
Yes, I'm Holger Kramer, a member of the European Parliament of Germany. I'm a member of the responsible committee, as you want. The ENVI and Public Health Committee is in charge of their issues. Thank you for this initiative and this congress. I think it helps to empower underestimated issues. I think hepatitis is one of the underestimated health risks, and that's why I thank you for this initiative. It seems to me that this, from you, proposed hepatitis care index, it is a useful tool. And I regret a little bit that the European Commission is not with us today. Do you have an idea why is that the case? Is that they don't like that index? How to work with it? And one remark to your presentation: it seems to me it is better to have a strategy, because action plan is sometimes is in Brussels sometimes the same as actionism. Yeah, so that's why I would prefer to have a strategy there. And yeah, thank you very much to enlightening us. And I hope this Congress will not only one point today. The question is how we can you encourage to continue that this initiative. Thank you.
So to your second point, I'm in line with your definition. But let me come to the first point. I think this is an overall situation now we have here in Europe, especially in Brussels. I have the feeling personally that the European Commission is no longer interested in one single disease. And for this, they are not here today. I think this is one of the reasons, because they do not want to focus their activities on one single disease. Although liver diseases are related to a lot of other diseases like diabetes and others. And I think this is something we have to work on together with you, the MEPs. And thank you very much, because your support in the past convinced a little bit the Commission to do some action specific there. But I think as long as they don't have any more specific data after the ECDC report is finished, they are not so feel comfortable to work in this field of hepatitis especially. And I think this is something so we have to work on, because what we need on the European level is that we need by the Commission the agreement that we need a strategy plan that we can roll out through the Council to the members of the European Union. And also it's very important that the European Union is supportive to the countries who not belong to the European Union, because this problem, when we go more to the eastern part, so it's getting higher and higher. So I think this is something we have to work together, and so with your colleagues, I think we are on the way.
Question over there?
Achim, Alain Volignan from SOS Hepatite in France, and SOS is a member of ELPA. I would like to support what you've just said. I mean, definitely we as SOS Hepatite would definitely support this idea of the plan, the action plan that you were discussing right now. However, we would insist on what you said before, which is that patients have to be involved in the design, patients' organization, but also we would add people who are responsible for structures where you have drug abusers, you know, people doctors who work in prisons, for instance, etc. They should be involved in that process. Now, to contradict you just a little bit about the European Commission, there is a model that exists, and Kuhn, who spoke before me, knows this very well. It's the Civil Society Forum on HIV at the European Commission level. And that's one specific disease where the European Commission has this forum for years with patients coming to feed in the discussions, to bring into Parliament for regulations and so on.
A very important statement when we go straight ahead to the next question. Right in the middle.
Hello, I'm Ebert Schatz, Correlation Network, and also member of the Civil Society on Drugs. So we even more focus on hepatitis C. And what sometimes concerns me is that there seems to be sometimes a kind of friction, or at least what you can say is that there's much more awareness on HIV, AIDS than on hepatitis C, and it is still the case. And I was very concerned seeing the first draft of the new EC drug strategy, Health for Growth, where hepatitis C not even was mentioned one time instead of HIV, also very much underestimated, but still at least was mentioned several times in the strategy. I don't know if the current evolvement of the strategy changed since then. I don't know if you can say something on that, on an updated version. But please also let me thank you again for this, what I think a very useful tool also for the future and upcoming years. What I, from my perspective, would appreciate if we could also work in even more detail on the aspects of drug use and hepatitis C, obviously. Thank you.
So just to update you, with the help of our MEPs there that supports us, we have now hepatitis included. So thanks again.
And therefore, again, these events are so important that we update each other on the activities, that we coordinate activities, and therefore, again, also it's not only ELPA alone, EASL alone, other societies alone. We have to really focus and to speak with one voice. Maybe one last question to the two of you. You mentioned frequently that you also worked on similar indices for other diseases. So can you, Arne, simply summarize there, how does hepatitis compare to other diseases? Can you give a statement on that one? So are we poorer, are we better, where we are?
I will highlight very encouraged clinicians. I mean, without them, the situation in Europe will be very much to cry. I think there is a lot of great physicians over there that without any help, just gathering and trying to learn from each other, they have been years without a general awareness and just trying to work forward for their patients. And that is something that every patient organization that I have been meeting also highlight. We have great clinicians. We just don't have the political phase, the policies behind that to regulate, to you know.
I was always mentioning that hepatologists are too shy as compared to others. Arne, last statement from your point.
Yes. There's one thing that has made us thoroughly depressed since 2009-2010. That is, unlike in private industry, when the financial crisis hit, the typical chief executive grits his teeth and says, I must get my company somehow through this. Frequently in the public sector, we see administrators and some politicians embracing the public sector under loud cries of, hooray, finally a perfect explanation for all the underachievement. And what Bea meant when she said initially, we try to measure things that people can change. And nobody can change the fact that the GDP of Romania will be lower than that of Norway for the foreseeable future. But in this index, we see that money isn't everything. You see a small country like Slovenia, certainly not the richest country, taking second place, mainly through the efforts of dedicated clinicians. And there's another tidbit in this index which shows it. The second most expensive standard procedure in modern healthcare is a liver transplant. Which country in Europe has the highest number of liver transplants per million population? You're not allowed to guess. Anybody knows?
Croatia.
Croatia, not Switzerland or Norway.
Okay. Very nice. Maybe last statement from my side on this one, why I think these indices are really useful. We are in Germany are right now working on our national action plan, strategy plan that we want to propose to our German authorities. And what did we do? We tried to look what did other countries do in Europe. So obviously we had a look at Scotland. We had a look at what was happening in France. And therefore I think this is a very useful tool that all of you can use when you go home to your countries. What can we learn from other countries? Sometimes it's simple things that have been implemented already, and then you can contact where can I guess it and what is good and what's maybe not as good. Therefore I think it's very useful. And for Germany we do not have this action plan yet. We hope that we can, it's in the final stage right now. We will propose it during the next few weeks hopefully. This also is very helpful information that we will include in this action plan. So thank you very much for your work. And I think we have to continue with the next session, and Achim will introduce us first. Thank you very much.
Yeah, thank you very much. So as I think this works too. So as Heiner mentioned, so what we've done now in Germany, I think this is the first thing when we started 2 years ago now, or 2.5 years ago now. We looked what exists throughout the world and best practices. And so we found the Scottish model and we found the French model, but also there was some Canadian modeling things. Australia is very good. And I think this is a future for hepatitis B and hepatitis C or liver disease in general, to learn from each other. And as I mentioned in my short summary of the index finding, now we have this strong instrument, and now we have to continue with all this finding to put together that everyone is now able to build his own national strategy. And for this we developed on this tool another tool that every country is really easy in the situation to build up strategy plan. But today I'm very happy to listen to very established countries like France and Scotland, but I'm also very happy because this year, one country I was surprised is Bulgaria. And Bulgaria is a big, big example that Bulgaria is on the way to have a very, very good national action plan. But also Croatia. Croatia, non-EU member, who did all the efforts to create the things. So I'm very happy to have now here in the second sessions living examples of what we can achieve when patient organizations and physicians and other stakeholders work together. So, and I'd like to introduce the first speaker, or you want to do it?
I will.
Okay, you.
Thank you. So very few words also from my side. Before we come to the Scottish data and the French data, I've been asked to give you a brief update on behalf of EASL. So what is EASL? It's the European Association for the Study of the Liver, and I want to highlight a few points why it's now worthwhile to talk about these issues now. Because obviously it makes no sense to screen, to make noise for a disease when you don't have a treatment at this stage. Then obviously you have a problem. And the key points I want to remind everybody about is that we are talking about viral hepatitis. And HCV, HBV, and also HDV, which is in some European countries a particular problem, is not equal to HIV, because cure is possible. So HBV can be suppressed, and we may have many, many patients who are infected with the virus, but who do not need any treatment. They have some level of spontaneous immune control, what we show. So it's possible to achieve this. And for HCV, it's even more dramatically. HCV is curable. And this does mean that the virus is eradicated from the body. A chronic viral infection, and when you cure these patients, you can take 10 liters of blood, if you would be able to do so, and you wouldn't find a single molecule of the virus, which I think is quite dramatic. So we have a chance. And
but you would if you took a piece of the liver? Or
no, you would not. You would not. In HCV, the virus is gone. And we come back to this one. So it's really, this is a remarkable...
Really, I still have it.
Yeah. If you treat successfully. So, the key point, however, is successful treatment is really the case that you can prevent progression of liver disease and in the end that you save lives. Just one example, which I think has been shown for many liver diseases, but is remarkable. This is a liver biopsy. So for those of you, you see on the left side, blue is bad, this is scars in the liver, and you see these tiny little nodules. And then you start treating a patient. After 1 year, it looks maybe a little better, and then you see after 5 years, this is a nice, thin, little piece of liver without a lot of blue, and this is regression of liver cirrhosis. So if you treat these patients, you can make things really better, and these scars in the liver can disappear, which is very important. And for hepatitis C, we've shown if you cure a patient, if you experience a sustained virological response, then you really save lives. Patients who experience this response, they don't die anymore that often, and you really improve the outcomes. We have tons of data now. This is important to keep in mind. Why is this important for Europe? And this is important for Europe because the disease burden caused by viral hepatitis will increase during the next 10 years. This is very important. So we have not reached yet the peak of disease burden. And when we talk about diseases, I'm a hepatologist, and this is what we want to prevent. This is a liver cirrhosis. You have a healthy liver, and then you develop a liver cirrhosis. A cirrhotic liver can still function. So this liver can still produce everything it's supposed to produce. It can detoxify things, and it can store compounds. This is fine. But if this takes for a too long time, then you have a problem. Then you may develop what we call portal hypertension. People may develop ascites, so fluid in the body. They may develop bleeding of the varices in the esophagus, and they may develop liver cancer. And where we are right now, many patients have been infected 20, 30, 40 years ago. This is data from France, and you frequently heard France is good. And here you see that the peak of diseases may be around 2012, 15. But this is France. This is, again, maybe the best case scenario, where we are for most other countries. This is my assumption, that the peak of liver disease will be somewhere between 2015, 2020, maybe even later for many other European countries. So it's time for us to act now, as Achim Kaus mentioned. And I just want to highlight one thing. We always talk about cancer. And we have been successful in many fields in medicine that we reduce mortality rates from cancer. This is data from the US, because we do not have that good data from Europe. But I want to show, this is the only US slide. You can see here that the deaths from different types of cancers really was reduced over a period of 15 years. The only cancer that dramatically increased was liver cancer. So liver cancer is a burden of Europe, and it is dramatically increasing, and patients are dying from liver cancer. And why to act now? The answer is because we have treatments. HPV treatments work in basically every patient if the patient is taking the drug and if the doctor is prescribing the drug. It works. And we have data from many different trials, and it works not only for 1 year, it works for 10 years. This is data, 99% of patients are negative after 5 years. 99% if the patients are taking the drugs. This is, I think, spectacular. And this is not only the industry trials, the best things we doctors like to show. It also works in real life. This is for the other HPV drug, for example, where it really works in 95% of data. We have the data. It is there. 95%, 99%, it works. And for HCV, we had a problem until recently, and until it will change right now, because we had to use these bad drugs. We had to inject interferon. You can only treat some patients, and you have ribavirin, which also has side effects. It's good, it was a step forward, but for 10, 15 years we had to work with these old drugs. And times are right now changing, because we have already the first new drugs, and I don't want to go into detail. We can target HCV at very different steps in the life cycle, and we have 50, 60, 70 drugs in clinical development. We have 2 new drugs licensed last year. There will be new drugs licensed next year, and we are really at a paradigm shift right now in HCV treatment, and cure of all patients will be possible in 2 to 3 years from now. And therefore we have to act now to identify the patients. This is what we have right now. We have many patients infected. Some are diagnosed. Few can be treated with these old drugs, interferon, and very small proportion we cure. When we have the new drugs available, we can treat many more patients, because more patients are treatable, and they, I mentioned, will be effective in basically every patient, 95% maybe. And if we have done this, then we can raise awareness, and then maybe we can diagnose more patients and cure more patients. And this is my message, why we have in the end to act now. And our responsibility is that we then provide tools to use these drugs in a responsible way. And this is the role of societies, medical societies. EASL is the European Liver Association, and we have guidelines. We have the HBV guidelines, we have the HCV guidelines. These guidelines are constantly updated. So the HPV guidelines have been renewed this year. We are now working on an update of the HCV guidelines, and this is the tool that we can give to everyone. These guidelines give very clear recommendations which patients to be screened, which patients to be treated, and the good news is not every patient may treatment now. We may still guide this treatment, but we give you very good recommendations how to use these important drugs. And I think this is the message that I wanted to make from the liver part. And now let's move on and hear some experience from different countries. And I first want to introduce John Dillon. He is from Scotland, and you have heard, so good news from Scotland. We will hear good news from France. And John, please tell us what has been achieved in Scotland, and we are very interested in seeing these data. Thank you very much.
Thank you very much for the invitation to come and speak. You can see Scotland that sits on the top of England, although we're now the UK, which has brought us down the league table. It's a novelty for Scotland to be brought down the league table by England rather than brought up, so we'll live in that one. So Scotland has a separate healthcare system to England and the UK, and so we have been able to initiate a healthcare plan for hepatitis C in Scotland because of it. And I want to take you through the process by which we thought about those processes. And so there was work formed in 2005 to look at what would happen to hepatitis C over time in Scotland. So Scotland has a population of about 5.5 million people. And at the time that this graph was constructed, we were treating about 225 patients per year across the whole of Scotland. And the little green sliver that you can see in the middle was the impact that we were going to have on the disease. and the large red bar at the bottom and the purple section were going to be the consequences of liver disease. And you can see that that timeline was ticking over, and the dotted line is on 2008 and 2020 and 2030. It carries on growing. And that worried the Scottish Government. 1% of the population of Scotland are positive. So we did some modelling work, and this is the key piece of data that changed people's minds. On your left, as you look at the graph, the uptake of therapy, continuing to do 225 drug users per year for their hepatitis C. The little red line was the numbers of liver failures and cirrhosis and deaths that we prevented by treatment. The blue, the bottom yellow and the top yellow are the consequences of cirrhosis, and it just carried on growing. If we upped treatment to 1,000 patients per year, and this was assuming that 50% of the treatment worked and 50% didn't, and so we were curing 500 people, we would eventually start to turn the shape of the epidemic in 2030, long after I retire. And so you'd be appointing new hepatologists to replace me when I left. If we started treating 2,000 patients a year now, and now being 5 years ago, we then changed the shape of the epidemic. We stopped it rising. We started to drive it down. And so by 2030, when I'm retiring, you won't need me anymore. Easel might become retirement home for all hepatologists. And that's the key turning point. Every population has a turning point, and we should know what our target is in each population. So we have 5.5 million people, 1% of our population is positive, and this target aims to treat 3% of your infected population per year and to cure 1.5% of them. If the drugs that we've just referred to become as efficacious as they are, then you can reduce the treatment number down to 1.5%, or you can keep it at 3% and make the fall off in the rate of cirrhosis even faster. So you need to know your target. This is what we're aiming for. That costs too much money, doesn't it? It's just not worthwhile. As you start to impact the epidemic, as people have already pointed out for me this afternoon, liver transplantation is very expensive, and it just is the tip of the iceberg. The huge numbers of people who die painfully and unnecessarily of liver failure over the weeks and months and years before their final death is huge. And as you start to reach the tipping point and you start to recoup the savings of that money, it becomes hugely cost effective. And so the cost over time, even when you discount for money that you're saving in the future, because that isn't as valuable as money you have to spend now, is hugely cost effective. And so it comes down to £5,100 per quality adjusted life year saved. This is eons away from the borderlines and the cut-offs to make it an effective intervention for healthcare. So there is no doubt that it is cost effective to do it. The size of the budget looks large because hepatitis C is a big problem. But if we don't do it now, if we haven't started doing it already, we're already spending money for our future generations and spending money in the next decades that we know we can't afford. So, having convinced our people in the top that we needed to do something, I think the key point is it's not just about throwing money at it. You have to be organised in how you do it. So how do we organise it? Each of it in Scotland is split into 14 health boards, so each territorial area has a responsibility for healthcare. So in each board, the government appointed one board member who was responsible for hepatitis C. So if it wasn't done, they were accountable and they were brought before the government to lead it. And there was a clinical lead who was appointed, a doctor, to mirror that politician or executive that controlled it. There was a network across Scotland, so linked good practice through all of those networks, and there was a rigorous process of audit and reporting, so that everything that was done was measurable on a national scale, and each board could be measured against comparable boards, so we knew what was going to happen. And within each health board, we established a managed care network, the network model, and that had a lead clinician who was responsible for organising the services. Most importantly, we employed hepatitis specialist nurses and key workers. The key workers were drug workers, anyone who was working with people who were infected with hepatitis C, and that could well be patient support organisations, it could be patient groups themselves. All of them were brought into the network, and these networks have been designed with input from patients beforehand. We thought about outreach. People who are ill, who are recurrently coming to appointments frequently for tests, etc., do not need to travel hundreds of miles to see doctors. They need to be looked after in their own locality. And so we took the workers to those, and we simplified and reduced the complexity of it all. So it was patient-centred, and again, audit and national benchmarking of those services was key to ensure that they performed. So what happened? You can see that year on year we had treatment targets. Each health board had to hit its treatment targets, and year on year each health board delivered over its, well, most years each health board delivered over its targets. Those years that some health boards didn't, other health boards made up for them, and those health boards were pointed out their failings and improved. And so we are now hitting 1,204 patients in therapy in the last financial year. We'll hit 1,350. And assuming that we were curing 50% of our patients, we're getting close to that 2,000 mark. But in reality, we are curing more of our patients than that, and so that number is very close to the tipping point. And you can see that this is the sort of data that is fed back to each health board. The health boards are identified across the bottom, so you can see each individual performance. So everyone was named and shamed if you didn't achieve the appropriate performance. And I can assure you there is nothing like a little bit of competition in our league table. No one wants to get demoted to the 3rd division. And so clinicians can be very, or the 4th division, as Scotland is for football, sadly. But so you can motivate those. There are enthusiastic health boards, there are less enthusiastic health boards. But when you've got a performance criteria that they're being measured in public against, they will match those criteria. Were we delivering good quality care? So the RCTs are the randomised drug company trials of the therapies, which took very selected patient groups into the trials. The English group is the Trent cohort based around Nottingham, and Scotland is all of Scotland. And we took all the patients we treated in Scotland with pegylated interferon or ribavirin, the first 1,000 patients. Were we delivering good quality care? Could we match the randomised controlled trials? And you can see that within the error bars we are. We appear not to perform quite so well in genotype 2 and 3. In Scotland we don't have any genotype 2. As you all know, genotype 3 is harder to treat than 2, and in the randomised controlled trial they had an even split. So if you allow for that, we are matching the randomised controlled trials. So with these networks, treating all comers without restrictions, cirrhosis, drug users, any subgroup you want, it's an open door policy to treatment. We can achieve those levels of SVR. That's a few years ago, and this is a single centre experience within Scotland, but it's mirrored across all of the centres. Year on year, the sustained virological response has got better as networks get better at working, supporting people through therapy, getting better at using the drugs, and any centre in the world which is using these drugs regularly will show these same figures, and so you can actually get the SVR rate all comers up to 70%. And so hopefully the new drugs are going to take us into the 90s, but we're already achieving a lot. So if you put that figure back on my previous graphs about how many we're curing, are we getting up to that 1.5% of our infected population cured per annum? Yes, we're just starting to tip that point. So we've started to hit that point where we're going to change the shape of the epidemic. Are we starting to see that yet? So if you take all of the patients in Scotland who have been entered into treatment, and because we can collect our data across the whole of Scotland, we know we've captured everybody. If you don't have an SVR, you are 53 times more likely to die of liver disease than the normal population. So it will come as no surprise to anyone in this room that Hep C is bad for your liver. If you achieve an SVR, your chances of dying of liver disease are reduced by 5 times, okay? Down to 10. And if you take out if you look at the impact of alcohol within that, that's the reason that keeps people high. Clearly, it's important, as Ina has referred to earlier, treating patients early. Cirrhotic patients can regress, but some people it's very late in the day for them, and they'll still get the complications of hepatocellular carcinoma. So if you look at those Those who are not cirrhotic, the process is even better. If you take out the alcohol effect, it comes back down into the normal range. Interestingly, if you look at patients who cured themselves and spontaneously resolved, who didn't have the benefit of interacting with the treatment system, they still don't do very well in terms of their long-term outcome. So that's another issue. But it shows that this is real-world data, and treatment makes an impact and changes the natural history of the disease and starts to save health boards money, starts to save governments money down the line. So where were we in Scotland in 2011? We would get so successful with treatment that we had got to the point where the number of patients with hepatitis C stopped growing. So we have 39,000 people chronically infected with hepatitis C. And that was balanced by the patients we cured, but sadly also by the patients who died. And was balanced by new infections in immigration and emigration into Scotland. And so clearly in time to come we want to stop the number growing, but we want to do it by curing more people and many less people dying. That pathway of care that Heiner in his first sets of graphs importantly illustrated is the efficacy of treatment, but it's the effectiveness of treatment and how good are we at delivering care to a whole population. As you go down, we have got, in 2011 we had 19,000 patients diagnosed, which was about half our epidemic. It's now up to 22,000. This is diagnosed HCV positive, PCR positive as well. In specialist care, 5,000, not in specialist care, 13,000. 3,000 of those are not in specialist care because they've already been cured and are out of the system. Okay? But we're still not doing perfectly. Initiated on treatment in 2011. So 20% of all those patients in specialist care started treatment in 2011. 4,000 didn't. About 1,700 of those have already been treated with the treatment that's available, and although these people are now starting protease inhibitors in 2012. And we're getting an optimal response in about 60% of patients overall, and this is ancient, older data, and it's moving up to always the 70% data that I showed you. So even in a system that is working well, we're not perfect. We still have gaps in the system. Now clearly, you can't have every patient in the system all the time because it needs to be the right time for that patient. It has to be about patient choice, and we wouldn't want, we're never going to have a system that's going to be 100% successful in terms of keeping patients locked in. It's not a police state. But we need to have a system that lets patients into the system to be treated when they're ready for treatment, and that they need to be, that opportunity needs to be offered to them recurrently. Where are we now? Scotland, I'm sure my colleague from France will argue with me shortly, is world leading for the delivery of hepatitis care. Our treatment targets will slowly rise as we come to that tipping point, but with the improvement in our SVR rates, we're getting much closer to that rate than we thought. HCV will become the core business of health boards, so it won't be a special ring-sent budget anymore. HCV infection will continue, and we need to work better at prevention. We have identified 50% of our epidemic patients, and we need to find the other half. And many of those are the patients that are difficult to find. They're not problem drug users anymore. These are people who may have experimented in the past and are older and therefore at much higher risk of progression. And we need to find effective methods of finding those patients. So we need to bring those into treatment. And our window of opportunity is closing rapidly. And in other parts of Europe, it's closing much faster because you haven't started yet. Where are we going to go? We're looking at new diagnostic testing. Dry blood spot testing has been very effective, and we've doubled our diagnosis rate in the last 12 months using it. We welcome the new treatments, but it's important to focus on that effectiveness. We need to improve our pathway to treatment. And we need to think about using treatment as prevention to try and shape this epidemic so that instead of constantly filling up the potential number of patients needing treatment, that we can lead to the eradication of hepatitis C where nobody gets infected because it doesn't exist anymore. Thank you very much.
Thank you very much, John. I think this is exciting data. John is leading the clinical group of the Scottish Government Action Group, and Scotland is leading. Let's see what my dear friend Professor Daniel Dumont is answering from France. Professor Dumont is really the father of hepatology of France. He was founding the French Hepatology Society. He was active in Paris for years and years, and he is also the mentor of Jean-Michel Pawlowski, who was leading EASL before me, and Daniel has not only interest in the science of hepatitis, of liver diseases, but he also has been involved in establishing these political tools that are so important and so successful in France. And he's also co-authoring, for example, a current very important analysis on the economic burden and the effect of treatment later on, and he will show us. Daniel, we are looking forward to your data.
Thank you, dear Heiner, for this kind introduction. So kind. And thanks to ELPA invitation for giving some data about French master plans. Probably because you postulated that the French master plans was related to the rather good results we had in France. And this is true. I will keep your slide. It's the same, but it's more recent. And you see that in this publication from the Journal of Hepatology, the rather good place of France, first for screening and management of patients. And because we are in charge of this master plan in France, we also postulate that this plan was related to this success. And we had many and successive steps in relation with Minister of Health and successive ministers. So many ministers of Health during these 20 years. And the first step was in 1996, you see, the implementation in France of 30 reference centers, so-called reference centers in hepatology. We could be involved for prevention, screening, and management of patients at the time with C virus infection. And we gave results, human results, to this center with approximately equivalent of a full-time physician. It's not so bad. And to be efficient in this field. And this was followed by the first national program, 1999. The second, only dedicated to C virus infection at that time, and for prevention, screening, management. Second national program in 2002, and we include at the time B virus infection, and we have now the third program, which starts in 2009 and will finish in December this year, at the end of the program. We hope we have other program in the future. And this French master plan, the present, is associated with the National Committee for Management and Prospective, which is composed of all factors, all actors involved in hepatitis for prevention, screening, management of B and C hepatitis. It's plethoric, 16 members, it's too much. But it's necessary because we are all representative from department, institute, minister, different minister of health. And it was necessary to have this, but the session is only once per year. And for regular follow-up of the program, we have a specific committee, including a full-time, it's very, very important, it's not me, full-time people specifically in charge of hepatitis and paid by the Minister of Health. You see the word prospective. I insisted to have this term included in the committee, in the program, because we could imagine at that time that the strategy could change within the 4 years of the program, and we have to adapt our strategy to the change in strategy, and it was right, especially with the arrival of triple therapy, of course. And this French management had many connections. And it will be the reason of the success, I think. Because we have connection with many departments of health, institutes, directions, associations, and you see the association of patients, and I see the president of SOS hepatitis there, and a very strong link with an agency for research in HIV infection and hepatitis now. And it's very, very important. And we have a department for prevention, for epidemiological survey, research, management, and I think it's good to control everything. But this network is important for the success of such program. The present program includes 55 actions. I will not detail the 55 actions, but these actions are included in 5 main strategic axes: to reduce risk of hepatitis B and C transmission, reinforce hepatitis immunization, and you remember the problem we have with the immunization of B in France. Solved now, so we have to be present. Develop hepatitis B and C screening strategy, and the right value could be approximately 50, more than 50% for C, less than 50% for B, but approximately is not so bad. It has to be improved in relation with the progress of therapy. Of course, we indicated that every 50 therapy will reduce the risk of cirrhosis, carcinoma, and liver transplantation cost. And I think we have to increase the screening, improve access to health care and quality for patients with chronic hepatitis B and C, adapt the recommendation measure to prisoners. I saw this slide, and I think it's very important because this population, you know, is at very high risk of transmission, have a high prevalence. And develop the knowledge of epidemiological surveillance and improvement of patient comprehensive care. I think it's very, very important. It's clear in the term of prospective. And as prospective, we try to anticipate the burden of patients with HCV genotype 1 infection. We will benefit from tenofovir or boceprevir, and the need, of course, for human resource in hepatitis reference center. And we present this work at the EASL. Thanks, Heiner, for accepting the paper. And it was published by Sylvie de Fick-Bosch and in Gut, see here. And Sylvie could show that the increase could be a factor of 3 or 4, comparing the present situation in France, and that we are waiting. At the present time, we have no results. That's it, but I am confident. but at that time, you had no human results for this patient. It's very important. And a second study was, we had a chance, we are lucky in France, to have a system, you have that in Germany, not yet, compassionate use. And with such compassionate use, we can treat the most severe patients before the full market approval. And you saw the results in the cubic model. And in last year, around 1,500 patients with cirrhosis, very severe cirrhosis,